Hello. We're excited that everybody has joined us this evening. I'm Jana Davis, and I will be joined tonight with Dr. Kimberly Zambito, as well as Dr. Kate Hernandez. But to start off, it's going to be a fast-paced program, but I think you'll enjoy having all of us speak, and hopefully you'll walk away with some pearls from all of our presentations. So I'm going to start. Again, I'm Jana Davis. I'm a functional registered dietitian nutritionist. I'm the owner of Bone Health Solutions in Charleston, South Carolina, and I see patients in person and many other areas virtually. But I'm going to talk tonight about an area that I don't think we hear enough about, and that is not just what to include in your diet, but how to improve digestion and absorption of nutrients so that we make sure that those nutrients get to our bones. And I just want to preface by saying I'm going to be giving some advice, but this presentation is for educational purposes only. It doesn't substitute for professional medical advice. And if you've heard me speak before, I do have an extensive bone health story. For the sake of time, I encourage you to go to my website, learn a little bit more about me, but I can share that I have been thinking about my bone health for about 60 years now. And that is one of the reasons that I'm so passionate about it. So if you've ever seen like a list of some of the risk factors for osteoporosis and osteopenia, many of them are going to be gut related. Things like when somebody has intestinal bowel disease, like celiac disease as well, or if they've had bariatric gastric surgery, maybe restricted intake of food, or somebody has been taking medication that impacts the absorption of nutrients. So I think most people are aware how much our gut impacts our bone health. But what we're going to do is really expand on that. And I'm going to talk about areas give you tips that you can include that are going to support the digestion and absorption, and also just more knowledge as far as things that can interfere with digestion and absorption. Just a little bit of review. Some people have not been on programs before, and I think this is just helpful to know as far as supporting natural bone remodeling. Just a reminder, their skeleton is usually fully formed by about the age of 25. Under favorable conditions, we're receiving a new skeleton about every decade. Obviously, that's impacted, as time changes, we lose estrogen, various factors. But just to remember that our bones are live, active tissue. And we have all these cells called osteoblasts, which are bone building cells, as well as osteoclasts. And those cells, we're always building and breaking down, and we want a balanced ratio of that so that we can get new healthy bone. When we look at a little bit of background on nutrition and bone health, certainly our diet is that foundational part. Protein makes up about 50% of our bone volume. So it's providing that structural matrix. And then we're going to fill in that matrix, that framework with the calcium and other minerals, and so that we can have strong bone. And I think many people are not even aware there are about 16 different vitamins and minerals that are actually necessary for bone remodeling. So it is a very complex process, and we need to have everything in place for it to occur. So why is digestion and absorption of nutrients so important for bone health? It's not just about what you eat, but it's about what you digest and absorb from your food, as well as if you're taking supplements, getting the full value of those supplements. You really won't benefit from all these healthy foods that you're incorporating into your diet if your digestion is poor. So you won't be absorbing as many of those nutrients that you need for bone health. So we're going to start with step 1 of digestion. And this is a parasympathetic state that we need to be in. So we need to be in a state called rest and digest. So relaxation turns on digestion, and stress, many people have heard the term fight or flight, but if we're rushing and stressed, stress is going to shut off our digestion. So as far as tips and things that we can do, when it is time to eat a meal or a snack, we want to sit down, we want to pause, and we want to take a few diaphragmatic breaths. So what we're going to do now, and this is going to take less than a minute, but I cannot emphasize how important this is. You can do it by yourself. You can do it in a group. I'll show you how to do it. Nobody's even noticing. So to take a diaphragmatic breath, what I want you to do, take your left hand and put it on your chest. And then I want you to take your right hand. Some people talk about putting it on your belly, but I like to put my right hand just when I'm demonstrating it, like right under my rib. So you can actually kind of feel that diaphragm. And what we're going to do is I'm going to breathe in through my nose. And then I'm going to do that to about the count of 4. And then I'm going to hold it for a couple of seconds. And then I'm going to breathe out to the count of 6. Now, if you go online and watch YouTubes and things like that, people tend to teach various techniques. You can breathe in through your nose and you can breathe out through your nose. And I like to do that. Like if I sit down at a dinner table and I might feel like maybe it's somebody that is going to stress me out. You can do it. You can do it through your nose and out through your nose, and nobody's ever going to notice. Or you can do it through pursed lips. So to begin, we're going to breathe in. You can keep your eyes open or you can close them. But we're going to breathe in through our nose to the count of 4. And you should feel that movement. If you have your hand below your rib, you should feel that movement. And then we're breathing out to the count of 6. We're going to do this a total of 5 times. That's less than a minute. One, 2, 3, 4. Hold for 2 seconds. Breathe out through your nose or through your mouth with pursed lips. Time. Hold 2 seconds. Last time. 1, 2, 3, 4. Hold 2 seconds. Now, I would encourage you, I hope everybody feels better. I would encourage you to do that every time you sit down to eat a meal. The magic number is like 5 to 15. So if you're by yourself, you can really do some work. I see so many clients with just, all kinds of issues with their gastrointestinal tract. And no matter what the problem is, this is going to be so supportive. And it lowers our cortisol. So it's going to help every cell in our body. So then we sat down at the table. We've pressed pause. We've taken a few breaths. The next phase, as far as really stimulating our digestion, is called the cephalic phase. And all that is looking at our food. If you had a dog treat and you held out that dog treat, what's going to happen? That dog is going to start salivating. So this is an anticipatory phase that's triggered by sight, smell, and thought of food. We start to get the production when we look at our food. You might feel a little silly. Had one client that was just giggling as they looked at their food. But when we look at our food, that starts to moisten the mouth, and that we get the salivary production, that saliva production, and that contains enzymes that'll be able to break down starches and fat. It also starts to activate our stomach. And our vagus nerve is involved in this. That's the longest nerve in our body. And that ultimately increases the production of stomach acid and enzymes available to break down food once it arrives. This is also just this one phase is preparing the liver and the gallbladder. So it's prompting it to begin releasing digestive enzymes and bile, which is going to emulsify fat. So I'm sure everybody is sitting there thinking, wow, I'm going to have to make some changes because what we have to focus on, and things have gotten a little out of control now. It used to be just TV trays, people watching TV, but now we've got cell phones. We don't driving, obviously, for safety reasons, but looking at computers. So we truly need mealtime to be about mealtime and not anything else but talking to our family and our friends, focusing on enjoying your meal. And that is going to have such a significant impact on digestion. So the next phase, we've taken a bite of our meal. Now we need to chew our food, back to just focusing on that. And I asked this question on my assessment form, and I can tell you a lot of people admit to not chewing their food very well. They eat very quickly because they're rushed, they're stressed. That's back to pressing pause, the importance of that. So we need to chew our food to break our food down mechanically. And then that saliva is going to start being able to digest carbohydrates. We actually do have an enzyme involved in starting to break down fats. And so the important thing here, the more that we chew, the more nutrients are going to be available. And the other benefit that you're going to get, if you are someone that gets bloating and gas, I can tell you, I have had people come in just for bloating and gas, and we work on these first 3 phases of digestion, and they're messaging me and calling me and saying, I'm great. They're expecting they've got to really do some really deep dives and take supplements and all kinds of things. But these foundational things make such a difference. Because if you just are, maybe it's a piece of broccoli and you eat it really quickly and you haven't chewed it and broke it down, time it gets down into your colon, like those bacteria down there are going to have a happy dance. They're going to be digesting it and fermenting it, producing lots of gas, and you're going to get bloated. So chewing your food. Something else I want to expand on too, as far as the actual digestion process, is the significance of having strong stomach acid. And a lot of the things that we talked about, we were prepping our body. We're getting our stomach to get the signal that we need strong acid. And when we have strong stomach acid, that allows protein to be broken down as well as fats. And then it breaks apart minerals from our food. And this is especially important, not just for our meals, but if somebody's taking a bone health supplement, we need to make sure that is with food because that's activated stomach acid. And that's going to allow the absorption of those vitamins and minerals. One thing that I want to mention is, and this is a big topic, but that is like on the risk for factors that medications that can impact bone health. If you've been prescribed a medication like a PPI, a proton pump inhibitor, H2 blocker, those, like I said, they do impact stomach acid. So when they lower stomach acid, that's going to lower digestion and absorption of nutrients. These drugs were designed for short-term use. Some people may need to take them longer, but that's a conversation that you need to have with your doctor because working on digestion can decrease the need for these medications and we can eliminate the reflux. Now, something that you can do, I'm all about food first, that you can do to improve stomach acid, and I'm glad to email you this list, is bitter foods are magical about stimulating the digestive system to produce more of those digestive juices, including the stomach acid, the bile, the pancreatic enzymes. So things like arugula, cruciferous vegetables, artichoke, orange, even putting, I think a lot of people heard, put a little bit of lemon in your water at mealtime, and that will start to help to activate some of these factors. Coffee is also a bitter food. And if you've ever been to Europe, many people have heard, like, they have actually bitters. You can take bitters, and they have bitters that they use in different drinks after a meal to help support digestion. So every now and then I will have to use actually some supportive bitters, but again, food first. These are always things that we can introduce that will make a big difference. I'm definitely a big bitter food person. So as we're going to continue to support digestion, there's a lot on this slide, but what the whole point of this is just showing you that it is not straightforward, that you eat a meal and you're going to get all these nutrients. And I think that's where a lot of people are like, confused and disappointed when they feel like they've been working so hard on their diet, but they don't see the outcome that they want. There's so many things that have to be in place to get nutrients absorbed in the small intestine. So calcium depends on having vitamin D. If we have malabsorption of dietary fats, that can actually impact absorption of calcium. We can have oxalates in our food that can interfere. Magnesium, the same. Dietary fats they precipitate as insoluble soaps, and that can compromise absorption. Protein, we've got that protein that's breaking down now into amino acids. We've got to have that in place for the collagen. But one point that I want to really mention is on the vitamin D and K2, which I know so many people are supplementing with. It needs the presence, all our fat-soluble vitamins. So our fat-soluble vitamins are vitamin A, D, E, and our K vitamins. So K2, we know how important that is for bone health, but it needs the presence of fat to be absorbed because those are fat-soluble vitamins. So if I've talked to people, you go to grab your water and you take your vitamin D, K2, and you haven't eaten anything, well, it's not going to be absorbed very well. So that's the kind of thing as far as just remembering how important it is to eat balanced meals because things work so synergistically. The other thing I was going to mention is that, and this needs to be an individualized situation, but digestive capacity often decreases with age. So many people may need supplemental digestive enzymes. So I do use some products after I've assessed somebody. I think many people have heard about our powerful microbiome. The last decade, we've learned so much about how those bacteria are truly running the show as far as our health. But just a reminder that our gut bacteria make vitamins, especially like vitamin K2 and our B vitamins. Those are made through fermentation of dietary fiber. So when you hear that recommendation, eat whole foods and don't eat a lot of processed food, that's one of the important reasons, because we need that fiber also to make those bacteria make short chain fatty acids for our body. That can boost calcium absorption. And having a healthy gut and a healthy microbiome, which is just the ecosystem of all these bacteria, we have less inflammation. And we have less inflammation in our gut. We're going to have less inflammation in our body, which results in less bone breakdown. Now, in my practice, I always try to have objective information. So I am able to analyze gut health and digestion. One thing I want to preface is that and I've seen this and I've had some incredible things happen. that have just been, we've been so thankful that we've done GI maps. But somebody could have no symptoms in their gut and have a major issue. Not everybody has bloating and gas and the obvious symptoms as far as their gut health. But this test is a stool test that I do, and I'm able to see like how much fat is in the stool. What do the pancreatic enzymes look like? Does somebody have a reaction to gluten? Is there inflammation in the intestinal tract? So we do have tools available to look at this if you feel like I've got to do a deeper dive on my bone health. So let's summarize a little bit. Factors that can interfere with digestion and absorption. I've mentioned many of these as I've gone through my presentation. Stress at mealtime, eating too fast, distracted and not chewing well, that low stomach acid, which can be as a result of aging or it could be reflux meds, eating a lot of processed food, excessive amounts of sugar and alcohol, anything that raises inflammation, high phytates and oxalates, so like not eating unsoaked beans or raw spinach. That's a big topic in itself. And then, as I just talked about, factors like dysbiosis is just having our gut flora out of balance so that there's inflammation. All of those factors interfere with digestion and absorption. So what can we do? Again, I think most people are going to be there. You're on this call to learn, and you're probably already trying to incorporate a lot of healthy foods in your diet. So to support the digestion absorption, to get that full food value, we want to have relaxed mealtime habits. We want to chew thoroughly. You want to incorporate those bitter foods that are going to stimulate that stomach acid and the bile release and the pancreatic enzymes that we need. We want to have balanced meals and snack. Again, snacks, everything works synergistically. I often see people do things like they'll eat a salad, but they don't want to put like oil and vinegar on it because they're trying to save calories. But again, that maybe that fat in that dressing, in that olive oil, is going to increase the absorption of the beta carotene in that carrot in that salad. So when we have this balance of macronutrients, it's going to improve the absorption of micronutrients. Always keep that in mind. One thing that I didn't mention that's also I put on here because I think a lot of people were taught fill up on drink a big glass of water and then you won't eat as much at mealtime. But we actually do need to limit fluids at meals to just what's comfortably needed. We don't want to overdrink because that dilutes our digestion and we won't get as much value out of that as far as our digestion. And then prebiotics, which I mentioned, having fiber-rich whole foods. Probiotics, we can be getting those from our diet, and those are going to help all those bacteria in our colon make other vitamins and the K2 and the B vitamins that I mentioned. So things like kefir and Greek yogurt and sauerkraut, those are also things that we can do. So in summary, our strong bones depend on optimal gut health. So we've got to support our gut to support our skeleton. And it's not just what you eat, it's what you digest and absorb. And I think if you'll, like I said, take a step back, kind of look at the process of eating, you'll have even better results as far as your bone health. All right. So I am going to pass it on to Dr. Hernandez.
That's me. I'm now going to share my screen. Okay. Everybody should be able to see that, I believe. Well, in a second, as soon as I hit share. There we go. Okay. So I am now going to talk about the power of exercise on bone health. As Jana said, my name is Kate Hernandez. I'm a physical therapist. I am Bone Fit certified, which is a certification through the Bone Health and Osteoporosis Foundation. I own a mobile physical therapy and occupational therapy practice here in Maryland. We have a program that we call Bone Wise, in which we teach people exactly how to start exercising or how to progress exercising with a focus on bone health. My story for Bone Wise, I'll keep it super brief. I was diagnosed with osteopenia at a pretty young age. I think I was 45. And not many people could direct me on how to treat that. So I went and got Bone Fit certified myself, really selfishly, in order to know how I can treat my bones well using exercise, and then realized that other people were just as in need of this knowledge. Um, I'm married. My husband's a high school principal. My older son just graduated from Ohio State and lives in Chicago, and my younger son is a freshman now at Ohio State. So big Buckeye fans here. And I just went over what is bone wise. I also have information about this on my website as well. Okay, the role of physical activity. We know it's been very well documented that it improves balance, it improves coordination, it improves strength, posture, and of course, it helps alleviate pain. On bed rest, bone loss occurs at a rate of about 1% per week, and it regains at the rate of 1% per month. Let that sink in. So if you or a loved one are in the hospital for 2 weeks and unable to get out of bed, you in those 2 weeks will lose about 2% of your bone density or bone. And then it's going to take you 2 months to regain that. The reason for that is because physical activity places an increased load or force on our bones, which then the bones respond by forming new bones and remodeling existing bones to be stronger. This is what's known as Wolff's Law, and it's the premise upon which all of the exercises that we prescribe for osteoporosis are based on. So, in summary, Wolff's Law is exercise exposes your bones to stress, which tells your body to build more bone. Now, why does exercise strengthen bones? There's mechanical stress that's placed on the bones, and this is a safe strain that is created on the bone. The osteocytes are the cells within the bones, and they are the sensors for that stress. Once they are triggered, they're going to start sending out signals for remodeling of the bone. Jana mentioned that there are osteoblasts, which are the bone builders. These are the cells that deposit new bone and create stronger bone where they're stressed. And then we've got the osteoclasts, which are the bone breaker downers. This with activity, we're going to decrease the number of osteoclasts that are present, which leads to less bone loss. So, guidelines for bone health. There are 3 essential elements that a good program will have. The first is progressive resistive strengthening. The second is power, and the third is impact. Dynamic exercises in short bouts are preferred over long duration exercises. There have been studies that have shown that athletes like soccer players actually have better bone density than that of a runner. And that's simply because athletes who play sports are constantly moving, stopping, starting, versus runners, which are more long duration, repetitive movements. Strength training needs to be progressive, and it needs to include resistance. So we always, if somebody is coming to us unfamiliar with strength training or unfamiliar with exercise, we always start them in a foundational phase where we do lower weight and higher reps, really to just build their confidence and make sure they have good technique. And then we're going to progress them to more moderate, high effort, higher weight, lower reps. And of course, balance training. If people are coming to us as a result of a fall and then a new diagnosis of a compression fracture with a diagnosis of osteoporosis, we are, of course, going to do balance training as well. There are four key principles to exercise in order to use exercise to optimize bone health. The first is specificity. It needs to be specific to target areas that have low bone density. This includes the upper body and the lower body as well. Again, you're going to hear me say this 23 more times. It has to be progressive. We cannot increase our bone density or improve our bone health if we are not increasing the weight once it's not challenging any longer. Potential. Everybody needs to understand that this osteoporosis, osteopenia, low bone density is not a death sentence. It can be improved. And we also have to understand there is a point where no more gain is going to be made. And by pushing past that point, you're actually increasing your risk of injury or further injury. So we all have to understand when to say when. And that's where professionals like physical therapists or a really good personal trainer can really help you with that, realizing when there's a plateau. The best exercises for bone health. It's not her. We all thought that was good back in the jazzercise days, but it's not. So, like I said, we start in a foundational phase. Not everybody, but the people who are not familiar with exercises need to learn the right control, the right technique. We're going to start them in this foundational phase. And it's really to build movement confidence. Patients who might start in this phase, those who are in pain, those who have an active compression fracture, and those just who have a lot of fear around exercising. We're going to work on posture, core, breathing, muscular endurance by focusing on low intensity and high reps. We're going to start in the position of comfort for the patient. So a lot of times that's lying on their backs. Once they have mastered things in that position where gravity is not involved, we'll progress them to a sitting and then a standing position. We're also going to teach pain management techniques and, of course, balance training if there's a fall risk. Now, Richard Simmons had it a little bit closer. He was almost right. That's a little better. There's some stomping in there. So once patients are ready and through that foundational phase, we will progress them to the advanced phase. So this is just taking the training to a more, the next level, more impact, more power focused, more advanced exercises, really to challenge the bones and the body. A lot of people start in this phase if they're already advanced and are familiar with exercises and form. So, like I said, progressive resistive strengthening, power exercises, which are more high velocity and explosive. That will be talked about on the next slide. And of course, upper and lower body weight bearing exercises for impact. So we can really implement that Wolf's Law. So these are just some examples of some power exercises. And the first one here, this is a clean and press. So he's actually using the force through his pelvis there to help drive that weight up to his shoulders. And then using the assistance of his legs actually to help push that weight up over his head in a quicker motion. This one is a squat jump. These are very advanced. We are not going to walk in, introduce ourselves, and start squat jumping. So there's a whole progression to get people to where they're comfortable doing maybe a mini squat to a jump. We start with mini hops at the sink. We progress those to jumps. This is a dumbbell swing. So again, this is using the power derived from a fast movement through your trunk and your core and your hips to drive that weight up to the shoulders. She's not using her shoulders at all for this. Now this one, this is a deadlift. These are incredibly important to teach patients. If you're at risk for a compression fracture, a lot of times that's going to happen when you are curling your spine. So it's impossible to go through your day without bending. We need to teach you how to bend though using this type of form where her back is flat here. She's actually hinging at the hips. So once people master that technique, then we can start to implement faster movements through the deadlift. I have to go through each one to get to the next slide. Here we go. I love this slide. So this just shows us there are so many different ways in order to get good impact on our bones. Each of these shows us how much body weight we are putting through our body when we're doing that activity. So lunge and walking is about 1 times your body weight. People always, always ask me if walking is good. And my answer is yes. If the alternative especially is to sitting on the couch and doing nothing, then please walk. If it's something you enjoy doing, you should do that. But I want you to also look here. So running is 2.6 times your body weight. Running, if you are a runner and then you're diagnosed with osteoporosis, you don't necessarily have to stop running, although that is under the guidance of your doctor and your physical therapist. If you are not a runner and you have osteoporosis, newly diagnosed, that is not the time to start running. It is a very, very complex mechanical movement that requires a lot of strength and a lot of control. But you do get 2.6 times your body weight. But look, step ups on a 12-inch step, you get just as much benefit from that. Heel drops, that is simply just rising up on your toes and letting your heels drop into the floor. You get 3.6 times your body weight. Foot stomping, 4.6 times your body weight. These are all very, very simple things that you can do even throughout your day to incorporate more impact on your bones. I have a good friend who every time she puts something in the microwave, she marches in place. Every time she puts something in the toaster, she does heel drops. Every time she does the dishes, she does foot stomps. So there are many ways that we can incorporate lots of good impact, safe impact through our bones. So I'm not gonna get in the weeds with this, but this clinical trial, but I am gonna go over the results from it. This is a very, very important research that was done. I believe it was 2017. It's called the Lift More trial. And these were the results. So the way this worked is they took 2 groups of postmenopausal women who had low bone mass, and they took a group of women with low bone mass who were postmenopausal and put them in 2 groups. One group was a home-based low intensity program like chair exercises. The other group was a high intensity progressive resistance impact training group. In that group, they did 4 exercises. These were completed 5 sets of 5 reps using a heavy weight, heavy determined by them, not heavy determined by the universe. So they did a vertical press, they did a deadlift, they did a back squat, which is simply a squat, but with a barbell across the upper part of your back. And they did a chin up, but they did that with a focus on landing. And I want to just briefly go over these results over here. The dark colored is the high intensity group. The lighter color is the control group or the low impact, low intensity group. We're only going to look at these first 2 categories here. The first one is the lumbar spine or the lower back bone density. And the second one is the femoral neck or the hip bone density. You can see in the control group that both of these things dropped over those 8 months. But in the high intensity group, we had a significant increase in the lumbar spine. We had a mild increase in the hip. I do want to mention that sometimes the spine will respond faster than the hip, depending on lots of factors, but most of which is the type of bone that is made up in the lumbar spine is a lot more metabolically active. So the fact that the hip did not drop at all, and in fact improved over a relatively short amount of time, is actually a win as well. This now is we're only going to look at the first 2. This is leg strength and this is back strength. And you can see again the comparison between the 2 groups. There was a significant improvement in the high impact group and just a mild improvement in the low impact group. So this study changed a lot about how we treat those with low bone density. Now, the topic you've all been waiting for, weighted vests. First, we're going to talk about how much weight, what activities, and safety guidelines. So the recommended weight for a beginner is to start light. I cannot emphasize that enough. 5 to 10% of your body weight is what you should start at. For more experienced people or for people who are phasing out of that beginner phase, can go up to 10 to 15% of their body weight. Now, the activity types and context. Walking and body weight exercises are a fantastic starting point. You still get the benefits of a weighted vest with less joint impact, and you're increasing that exercise intensity, but doing it in a really safe way to start with. Strength training, plyometrics, sprinting, please do not start there. Actually, I'm a PT, so if you want to start there, you're actually helping our business grow. Do not start there if you don't want to get injured. It's not safe, it's not smart. In fact, strength training, plyometrics, sprinting, highly advanced activities like that really should be under the guidance of a physical therapist or highly skilled personal trainer. Avoid long duration or high impact runs initially. Always start short bursts and increase slowly. Ensure solid technique. So you want to ensure solid technique in basic movements first, squats, push-ups, lunges, and then try it with a weighted vest as long as your technique is solid. You want to progress very incrementally. So increase training volume before you start adding more weight. Listen to your body. If you have pain with you using a weighted vest while you're walking, but you did not have pain before, stop using the weighted vest. Talk to a professional. Protect your body. Frequency guidance. Start with 1 to 2 sessions per week that are short, 10 minutes, and then continue to increase from there. Now, the good news. These are all the things that a weighted vest can do. They do really, really great things when it comes to calorie burn and cardiovascular demand. Studies show 12% more calories burned when using a vest, equal to about 15% of your body weight. It's going to really help target muscles in the legs and the core and the stabilizers. So weighted activities like squats and push-ups, like with a weighted vest, that's going to enhance muscle building potential. And we all know that building muscle is going to protect our bones, especially if you have a fall. So that's a good thing. It's really good for fitness. There are slow pace walking with a vest will boost your VO2 max. And just your overall heart and cardiovascular system will be improved. Improved balance and functional stability, which of course would reduce fall risk. And we cannot lie, it's convenient and it's super accessible. It doesn't require a gym membership. You could just incorporate a weighted vest into your everyday activities to make it beneficial. What studies show? It's very little, guys. So this is the not so great news. So when it comes to bone health, there just really aren't great studies yet out there. The concept of adding weight to your body while doing impact-driven exercises makes sense that would help with your bone health. But it's hard for somebody like me to suggest that until I see research that is supporting that. So there are old studies from 1993 and 2000 that showed very slightly increased bone density. We're talking a 1% gain in people that were using weighted vests. The problem, in addition to these being older studies, they were very, very small. So there were 18 subjects in one study and 36 people in the other study. Those just aren't quality studies that we can really derive a lot of great knowledge from. There was an INVEST trial in 2025, which was a trial of 150 older people who were obese but lost 10% of their body weight over 12 months. This found that daily weighted vest use, so that was about 7 hours per day, did not prevent hip bone loss. Bone loss rates were similar across vest use, resistance training, and weight loss only groups, suggesting no added benefit of weighted vests for skeletal health compared to traditional resistance exercise. And that's sort of what we have to go on when it comes to research right now. So this is a very hot topic. The problem is that I think people are grabbing on to studies that just aren't quality studies yet and trying to anecdotally derive their own conclusions about what it did for increasing bone density or improving bone health. So keep all of that in mind when you're using when you're using a weighted vest. This is my information. Of course, you will have access to this in the recording. So without further ado, we'd like Dr. Zambito to go next. So I'm going to go ahead. Oh, Richard Simmons even wants her to go next. I'm going to go ahead and stop sharing. I think. Yeah. Um, why can't I find where to stop sharing? Okay, I'm having problems here.
Let me see if I can you see
Yeah.
me?
Nope, I'm having some problems with my own computer right now. Okay, hold on. Jana, are you able to stop share for me? I don't know what's happening right now.
We have Dr. Zambito's slides up, though. We're good.
Oh, okay, good. That's fine. That works. Thank you.
Okay. Let me see if I can see my slides because I still see Richard Simmons dancing. But okay. So you can see my slides okay?
I can see your slides, Dr. Zambito.
Great, great. So this talk is really about focusing on knowledge and empowerment with REMS, radiofrequency, echographic multispectrometry, or the Echolate REMS study. Jana, you already stated a disclaimer, and I'd like to reiterate this. This is not intended to be used as medical advice, and it does not establish for me a doctor-patient relationship. I do have no financial relationships with industry, meaning there's no industry that pays me as an advisor or anything like that. And I am the owner of Z Medical Solution, and I do business as Qualisas, which means quality bone. I always like to start my presentations and end my presentations in a similar fashion. Not everybody has been exposed to osteoporosis or bone health. Some people are new to it and are lost in the weeds. So I like to start with the definition of osteoporosis. It's a systemic skeletal disease characterized by low bone mass and microarchitectural changes of the bone tissue. And this leads to increased bone fragility and consequent increased risk of fracture. This is defined by the WHO. Osteopenia is not a diagnosis. It is a description for low bone mass or decreased calcification of bone without a clinically increased risk of fracture. That being said, approximately 50% of people who sustain fractures have normal bone density or low bone density, meaning they don't have osteoporosis. There are factors that we can change and there are factors that we cannot change. And so the ones that we cannot change are our ethnicity, our genetics, our body frame, and our gender, and the fact that we're all aging. The things that can be changed are our nutrition, as Jana spoke about, our physical activity, as Kate spoke about, the use of alcohol and tobacco, hormones. We can consider taking HRT, and our mindset. A positive mindset is huge when it comes to any type of medical condition that we're dealing with. The medical condition itself may affect your bone health, but in some instances, it's the medications used to treat the medical condition that can affect our bone health. And Jana illustrated that so well with PPIs and H2 blockers for GERD, or gastroesophageal reflux disease. Any workup for osteoporosis can include the following. So an imaging study such as a DXA scan, calcium, serum calcium levels, vitamin D levels, thyroid stimulating hormone, parathyroid hormone, renal function, RBC magnesium, and other lab work is needed. So usually your physician will decide what they want to order when it comes to looking into your bone health. I also want to stress the importance of a physical examination. So looking for the presence of a hump on your back. We used to call that a Dowager's hump. It's clinically it's called kyphosis. They can perform tests like a timed up and go. This gives us an idea of your functionality as well as your balance. We can look at loss of height over time, and we can also look at loss of muscle mass over time. However, many people receive the diagnosis of osteoporosis after having a DXA scan. So we're going to go over how that diagnosis is made and how it's defined in terms of the DXA results. Other people may receive the diagnosis of osteoporosis related to clinical circumstances such as a broken bone. So if you have normal bone density, you're going through your life, you trip, you fall, you break a wrist, you break your hip, you break a humerus or your arm, that by definition is osteoporosis. Clinical definition of osteoporosis. What is DXA? DXA is the most commonly used tool for measuring bone mineral density. It is considered the gold standard. It's measured at the central and peripheral sites, meaning it's measured at the spine, the proximal femur, which is what we refer to as the neck, the total hip, and the trochanteric region, and the wrist. Sometimes people come to me and they're very confused, thinking that their neck was scanned. The neck on the report is referring to the femoral neck. It is a specific anatomical part of the proximal femur or the hip area. Downside, or one of the concerns that people have when it comes to DXA scans, is radiation exposure. It's not just the one-time radiation exposure, but the cumulative effect of radiation exposure over time. The amount of radiation exposure per DXA scan is very low. It's less than going out and enjoying a day of gardening in the sun. DXA reports will vary from facility to facility, so it is important to obtain the full report with the images. So if somebody comes to me with a consultation and all I see are numbers and words on a report, that will not suffice. I need to see the images to see if the DXA was performed correctly, and if what we call the edge detection was performed correctly, the positioning was performed correctly. So in order to do a very good critique of a DXA report, I need to see the images. When it comes to following our bone health over time, typically about 2 years is required to measure any changes of bone mineral density via DXA. If you're on an anabolic medication, meaning a medication that builds bone, you may be able to see those changes at annual or yearly intervals, and your doctor may order a DXA scan annually while you're on that medication. That being said, when it comes to interpreting a DXA, we have to take into consideration the least significant change. The commonly accepted least significant change, meaning this tells us this change on your DXA is real, most commonly accepted is 5%. Some DXA reports will have their least significant change printed on the report, but if it is not printed on the report, we're looking at a 5% change, and that's referring to the bone mineral density, not the T-score. There's an added software package to some DXA machines. It's called Trabecular Bone Score. And the purpose of this software package is to look at the bone quality. So the TBS score is reflective of bone quality. It's done only on the spine. It is not done for the hip. And it is more predictive of fracture risk than bone mineral density alone, or clinical risk factors, or FRAX. And I'm not going to go into FRAX, but if you want to Google search FRAX, F-R-A-X, you'll see that 11 to 12 questions will pop up. You can answer those questions, and it'll give you your risk of major osteoporotic fracture and risk of hip fracture in 10 years. Oftentimes on DXA reports, the FRAX will be included on the DXA report. The downside to the TBS is it is dependent on the image quality from the DXA. It is dependent on the edge detection. If there's a vertebral fracture, you need a physician who is interpreting the study, who can understand, hey, this vertebra should be excluded. And it can be affected by BMI, meaning our body mass index can affect our DXA results. So how is osteoporosis diagnosed by T-scores and what we call Z-scores? Z-scores compare you to a 30-year-old Caucasian female. Z-scores compare you to your age, ethnicity, and gender match. So we define postmenopausal women with a T-score of -2.5 or less at any region of interest. That is defined as osteoporosis. So we do not say I have osteopenia at my spine and osteoporosis at my hip. It's whatever the lowest number is, doesn't matter the region of interest, that is your diagnosis. For men over the age of 50, it's a T-score of -2.5 or less at any region of interest. For women in transition, the WHO criteria is a hip score at -2.5 or less. And then for younger people, women prior to menopause and men younger than 50 years of age, we go with Z scores of a -2.0. We don't use the diagnosis of osteoporosis, but we do say this person's bone mineral density is below expected age range for age. So I'm going to briefly talk about Echolote REMS because I do offer this service. And this is the test that I find is very, very useful when we're looking at bone mineral density, but also bone quality. It is an ultrasound technology which was developed by Echolote, the company. Some people will call this the Echolote test. The technology itself is called REMS. It analyzes ultrasound backscatter. And then those signals are processed and compared to acquired spectra. So what does this mean? I place a probe on your abdomen to evaluate your spine, or I place a probe, also called a transducer, on your hip to evaluate your hip. Sound waves go down to your bone, they interact with your bone, they bounce back to the transducer, and then they are evaluated through artificial intelligence or computer processing. So a REM scan is performed where you're laying on your back. We can perform it in other positions or modified positions, but standard is laying supine, so face up on an exam table, as you see in the photograph here. The lumbar spine, we measure L1 through L4, similar to a DXA. The hips, we measure the femoral neck, not the neck, the thing that our head sits on, the intertrochanteric region, and the total hip, again, similar to a DXA. So similar information. The reports are generated for each body part within minutes, and the total test takes about 15 to 20 minutes, provided that there's no issues. Occasionally, I have to rescan somebody for whatever reason, so I usually book for a 30-minute slot for these. This is what a REMS report looks like for the spine. The top left part of your screen is the first page. It is a summary page. I will say that the new REMS reports, or the updated format, is a little bit different than what you see here on the screen. Page 2 is the fragility score. The fragility score is a reflection of the bone microarchitecture or the quality, and I'll review that in a few slides here. And then page 3 compares your combines your T-score with your fragility score to develop a risk classification and to tell you what your risk is for the spine. The spine represents major osteoporotic fractures. It'll tell you your risk at 5 years. And here's the REMS report for the hip. So very similar information. You have a picture of the femur. This part right here is called the femoral head. This part that's color-coded is called the femoral neck, not the neck, the thing that your head sits on. This right here is called the trochanteric region. And then when we take the femoral neck down to just below the trochanteric, to this area, the trochanteric region, that's what we call for that's what we call the total hip. So what is the fragility score? It is a big deal. The fragility score is a reflection of the microarchitecture of the bone. So when we look at the report, there's a score of the fragility score that can it can go from 0 to 100. And different than what we're used to thinking. We're thinking 100 is a great score. Yay, I scored an A on my test. That is not how the fragility score works. The lower the score, the better the bone quality. It is independent of bone mineral density, meaning that The density of your bone has no play in terms of the fragility score. The way the fragility score was developed is it takes bone signals, it takes your bone signals, it processes them, and it asks the question, does your bone microarchitecture compare to people who have had a fracture, or does it compare to people who have not had a fracture? And so that is how the fragility score works. You're assigned a number, and then it is displayed on the graph that I showed a few minutes ago for the fragility score. The fragility score was found to have superior predicted value for fracture when compared to bone mineral density derived from DXA or from REMS. So what this tells us is that the quality of the bone matters when it comes to fracture risk. Oftentimes when people come to me for a REM scan, they want to know which test is correct. Like, what do I believe? They're different. I get different information. REMS was developed with DXA used as the gold standard or the baseline. And when we're doing research projects, the idea is to control various factors. So when we're developing something such as REMS technology, we're able to control the quality of the DXAs that are being done and the quality of the REMS that are being done. And so DXA was developed with REMS as the gold standard. However, when we go out into the community, there are different variables which can affect our DXA results. And so sometimes we see that the DXA results are very different than the REMS results. And that's why it's really important to have somebody who understands how to interpret these and critically analyze these so that we can give you good information for you to make the best decisions for yourself. So DXA and REMS can be used for the diagnosis and monitoring of bone health. There are pros and cons to each of them. So when you get your REMS after you have your DXA, make sure to compare your DXA to DXA over time and your REMS to REMS over time. Don't get your DXA and then a year later get a REMS and then compare the two to see if you've progressed. You have to compare DXA to DXA and REMS to REMS over time. I thought this study would be of interest to everybody in this talk. When I choose studies, I choose open access studies, which are free. So you can go on the internet, Google this, and pull the article for yourself. This study showed that 93% of DXA reports had at least one error. 79% of the errors were in data analysis. 12% were related to patient positioning. 7 were related to artifacts, and 2 were related to demographics. So it is important to look at the DXA critically, just as it is important to look at a REMS report critically. Any report you have. When comparing the technology, REMS technology to DXA, you may see some some minor differences. And when you accept a 0.3 tolerance for the T-score, in this study, there were no cases that were diagnosed as osteoporosis by DXA that were defined as normal as REMS. So I do like using REMS in terms of monitoring bone health over time. I feel that when done properly, it gives great information and provides me with more insight into the bone quality, which we don't get with the DXA. This is something that I think you'll appreciate as well. This is bone geometry and size matter. So this study used phantom vertebral bodies of various sizes and performed DXA scans on them and then analyzed them. In a nutshell, for smaller bone sizes, i.e. petite people, petite bone sizes, they found that DXA tended to overestimate osteoporosis or overdiagnose osteoporosis. So if you are interested in learning a little bit more about how bone size affects your DXA results, I would recommend reading this article. REMS also expands our ability to screen and monitor bone health in other situations. So when people have spine fusions, we are able to still do REMS scans on them. For DXA, we cannot image the vertebral bodies from L1 through L4 if there's instrumentation at that level. We can do it following scoliosis surgery and certain hip surgeries, provided that there's enough bone tissue available for the analysis. It cannot be used following a total hip replacement. So if you've got a hip replacement, that hip cannot be imaged. REMS is not affected by degenerative changes. Unlike DXA, REMS results are not affected by osteoarthritis because the computer software eliminates those changes that occur in bone that are related to osteoarthritis. In DXA scans, sometimes people will track their spine results over time and they see a small improvement over time. That improvement can be related to osteoarthritis, not necessarily a true increase in your bone mineral density. Again, it is critical to have somebody who can analyze and interpret those results for you. So here's a nice little chart. How will my DXA and REMS results compare? DXA does bone size affect DXA? Yes, it does. As I gave you guys that article a few slides back. For REMS, it is not affected by bone size and bone geometry. Can DXA be affected by positioning? Yes. If the positioning is done incorrectly by the technician, it can affect your DXA results. For REMS, no. In terms of osteoarthritis, artifacts, instrumentation, can DXA results be affected? Yes, they can. For REMS, they cannot. And is there variation between machines? With DXA, you need to go to the same machine every time in subsequent years. For REMS, you do not. The precision of the REMS device is such that you can go to a different REMS machine, you can go to a different REMS technician, and there won't be any difference between the results. Mind you, there are some least significant changes that we have to consider, but for the most part, there are no differences. There's no error between the numbers. Most importantly, you are more than your DXA or your REMS results. You're an entire person, and your overall health history matters in assessing your bone health. So there are things to look at when making a decision about the treatment for your bone health, and those things go beyond DXA and REMS reports. Also remember that you know you. Recognize that you're an individual and what works for one person may not work for another. I absolutely love the communities for bone health. There are some very supportive people. I'll get on and observe some of these discussion groups, but there are also some, you have to be careful with what advice is being given sometimes, especially when somebody doesn't know your entire health history. So I encourage you to learn and grow and engage to optimize your health because nobody's going to care about your health the way that you do. And I'm announcing at this event that I am coming to Charleston, South Carolina, November 6th and 7th. If you are interested in having a REMS scan, you can scan the QR code at the bottom of the slide, or you can go to my website, which is www.qualisos.com to schedule your REMS scan. I also do consultations via Zoom. Those consultations are for educational purposes. They're not for making medical decisions for you or on your behalf. I also have a lot of free resources on the website. So the video library and the blog are wonderful, wonderful resources. The blog is written by medical professionals. Myself, Dr. Bush, and Dr. Birch have contributed as well. So we are very dedicated to educating and empowering you so that you can make the best decisions for you. So I'm going to stop the screen share now. All right.
Excellent. So we're going to do a Q&A now. All we ask, and there's already there's a 9 here next to my Q&As. All we ask is please stick to the topics that were presented today. Do not present your personal history. We can't provide personal advice to you today in this forum. And 1 question per person just to keep it moving along here. So I'll go ahead and open this. There was one at the beginning. It said I had gastric bypass. Okay, so can you address absorption for bypass patients?
Absolutely. And I think if when you had your surgery, typically people are given a protocol, and that's called the protocol for life post bariatric surgery. And that includes calcium and other vitamins that are, it's very well studied that we're not going to be able to get as much absorption after bariatric surgery. So my recommendation is, I don't know as far as details with surgery, but go back, see what your provider prescribed. Um, I have seen, I'll be very honest, I've seen some protocols fall short. That's an area, feel free to reach out and I can give you lots of specific informations on an individual basis.
She also said she's wondering if there's a higher quality multivitamin besides the bariatric ProCare multi.
Absolutely. But that's again, that's more personalized, but there are absolutely some wonderful products. And then there's some products that are subpar.
Okay.
But
Examples of fat to eat with K2 pill. And then she said like cheese. Would that be an example of a fat?
yeah, but also healthy fats, olive oil, avocado, nuts, some walnuts, um, plant-based sources, but cheese, yogurt, like a whole milk yogurt, some kefir. Would have, if it was made with whole milk, then would all be good sources. Great question.
Okay. It's this is a Dr. Zambito question. Is it important to have repeat REMS done at the same place with the same technician? I think you probably answered that. So the answer is yes. I can actually answer that.
So for the DXA, it is important. For the REMS technology is so precise that you do not need to go to the same REMS machine or the same REMS technologist. That being said, you want to make sure that you have somebody who is experienced and who has good knowledge of the anatomy, ultrasound technique. So those are the things that I would recommend. And with any new technology, for example, with REMS, when you first start using it, it's a lot of eye-hand coordination. And so for somebody who's new at that, you need to take that into account. Any technology that we use, we all have to learn how to use it. And so if you're concerned about a technologist's experience, you can ask them that question.
That sort of leads maybe to the next one. Can you address a bit of info about the advantage of adding a 3D shaper to my REMS and DEX data?
So the 3D Shaper is a software package which is added to a DXA. It is not added to a REMS, okay? And what that does is it's looking at the geometry of the femur. It is an experimental technology at this point in time. So mostly universities are getting it, not so, for research purposes. They're not used on a clinical basis at this point in time. So that's really all I can share with you. I don't know if we have any guidelines on how to really use it, but I do find it intriguing simply because there is research out there that femoral neck shaft angle, as well as the size and the geometry of the femoral neck, can play a role with risk in terms of risk of hip fracture. So I think it's really cool technology. I'll be curious to see how it becomes of clinical benefit in the future.
Great. The ability to hit the focal point and depth, is that indicative of the sonographer's experience when they perform a REMS?
So the sonographer should understand the anatomy, number one, what they're looking at on the screen. Number two, they should understand how to manipulate the transducer so that they can get the best possible image on the screen, but also they do have to hit the correct focus and depth in order to get an accurate reading. The technology for REMS is great in terms of if it doesn't get the data that it needs to process it, it won't process a report. However, some of the reports that I have seen, the REMS the REMS technology will process a report, even if the focus and the depth are a little bit, or the image isn't properly in the frame. So I think it's important to make sure your sonographer or whoever is doing your REM study is getting adequate imaging.
Okay, we'll give you a break for a second. Jana, do you recommend calcium and vitamin D supplements?
Um, Again, that needs to kind of be individualized because there's a lot of factors. But I would say more than not, I use bone health formulations that have an absorbable form of calcium. Not everybody's taking an very absorbable form of calcium with some vitamin D and then some K2 included in that. But again, we have to look at, what is somebody's vitamin D level? Do they have heart disease? I mean, there's so many variables, but definitely, it's food first, but not everybody can get enough through their diet. So we might, that's what a supplement is. It fills that gap. Yeah.
Okay, Dr. Z, you're back up again. Can a REMS accurately read lumbar bone quality for someone with scoliosis, lumbar scoliosis?
Yes, yes. You want to go to I'll be honest with you, you want to go with an experienced REMS technologist, whether it's a physician or an ultrasonographer, because with scoliosis, it's not simply a curve, it's a curve with a rotation. And so you have to manipulate or modify your positioning on the probe in order to get appropriate imaging.
Okay. How often should a REMS test be done?
That's up to the individual. So the REMS technology is sensitive enough to pick up changes at 6-month intervals. I feel that is really overkill. If you want to get it done annually, I think that's perfectly fine. If you want to do it on the opposite year of doing your DXA, so let's say you get your DXA in 2025, you do your REMS in 2026, you get your next DXA 2027, then you've got 2 methods to measure your bone health over time. And what I want to stress is these are screening technologies, just like a mammogram, right? I think Dr. Bush does such a great job when he describes what these technologies are for, and it's also included in one of the blogs. We're screening for the, oh my gosh, what's going on here, right? Like our mammogram isn't looking for normal tissue, it's looking for the, holy cow, we need to do something here, right? Same thing with bone health, right? So we're looking for that drop in bone health, your BMD over time, not necessarily, trying to manipulate your bone density. We've all been brainwashed to want to increase bone mineral density. And if you recall at the beginning of my talk, 50% of people who have fractures have normal bone density or low bone density. They don't have osteoporosis, right? So that tells me there's more to this than just bone mineral density, right? And I've already discussed that bone quality matters as well. But the things that Kate talked about and Jana talked about really matter. Fall prevention is huge. I can't say as an orthopedic surgeon, I've taken care of anybody who had a spontaneous hip fracture. Is it possible? Maybe. But typically there's a fall and then something happens. And so fall prevention is huge. Like increasing your bone density isn't going to prevent you from falling. Taking care of your muscles, your balance, your mobility, your flexibility, all of those things are what's going to make a huge difference. So try to use these technologies as screening tools and monitoring tools, but don't drive yourself nuts trying to, see changes in the numbers. It's very satisfying, but this is not a test that we take in school and we can get a 100% red with a star sticker on our paper. So that's my soapbox.
Excellent. Is there any place in Maryland near Ellicott City that you could recommend for a REM scan? I can actually answer this. Yes, I've been told Dorsey now has a facility that is offering REM scans. I don't know if Dr. Z, I don't know if you know the reach into Maryland, but Karen, if you would like to email me, I can give you more information about that. So that one. Okay, in your experience, is there any research in yoga and improving bone density? There just isn't a lot of impact in yoga, but there is a lot of, especially upper body weight bearing. So certain positions in yoga are going to give you a lot of really great upper body weight bearing and impact that can help with all the things that we need for bone health. But it's mostly low impact for the lower body. Now it's great for core. It's great for trunk control. There's a million benefits to yoga. There's also some, you have to be careful if you are prone to compression fractures. There are certain positions you need to avoid so that you're not placing increased stress on your spine in those positions. But so I hope that answers. Okay, I'm going to come back to that one. What DXA or T-score is safe to perform impact exercises? If the spine is in osteoporosis, not osteopenia, are they contraindicated? Dr. Z, I don't know if you want to take that or if you want me to.
I think we can both take it together, Kate. You have to look at your whole picture. You can't just do it based on a T-score. You have to look at the entire individual.
Yes, I totally agree. It's hard to answer that question because there's a lot of factors that would go into making that determination if it's contraindicated or not. Okay. Are there any recommendations for osteoporosis of the jaw? I don't have any.
I'm not sure if that person is referring to osteonecrosis of the jaw.
That's what I was thinking. But then she asked exercises to strengthen, or will these bone building exercises impact all bones in the body?
I can share something exciting.
Oh,
I have a client, I actually have this testimonial on my website, but I had somebody come to me in tears because they were told that they could not get a tooth implant because they did not have enough jawbone. And she's just like, I'll do whatever you tell me. Like, we did a deep dive. We looked at her digestion and absorption. We looked at hormones. We did a lot of things, worked on it for 8 months. And she, just did everything, really worked on her diet. And 8 months later, she had jawbone and was able to get her implant. And that was 4 years.
oh, you're freezing.
So that just really illustrates right there, Jana, the importance of the entire person, not just focusing on T-scores and looking at your nutrition, it's an entire person that you're looking at. And so if I could do one thing and convince people to stop obsessing over T-scores, that would be the magic wand that I would want to wave. You realize that you're an entire person. And the T-score is just a part of the puzzle.
Exactly. How are we on time, everyone? We okay? There's a couple more in here. Okay. So Lisa had a question that she entered that she entered the question when she registered. I do not have access to that. And it's a Jana related question. So what I'm going to tell Lisa is to please email Jana that question so that she can provide the answer to you. Jana, if you want to jump on and just speak your email so that Lisa can write it down. Unmute.
Yes.
Yeah.
I was trying to get to it. So yeah, my email is bonehealthsolutions@gmail. And I would be glad to look at that.
Okay. How does TBA via DEXA for bone quality compare to fragility score via REMS?
I'm not aware of any research studies that have compared the two. Anecdotally, people who come to me with a TBS, and again, TBS is only for the spine, it doesn't do the hip. So they correlate pretty well. But again, that's anecdotal. And I'd want to see some research on that to compare the two.
Okay. Can the fragility score be unexpectedly lower than expected based on the rest of the REMS exam, which was highly consistent with DEXA?
So I'm not sure what that question means,
No,
but I will say that I've seen some people, a handful of, people that I've scanned where they have normal bone density, but their fragility score is very poor. And that can happen, right? So I've had, people who are stout, I'll say, not very petite, have great bone density, but then their fragility score is really poor. Those people had diabetes, or had, some sort of cancer for which they had treatment for that. So there's, some sort of medical background that has happened. But yes, that can happen. I think I'm answering that question appropriately.
There's a couple of questions about REMS being offered in the Orlando area and in the Memphis, Tennessee area. I don't know if you guys have insight to that. I don't, but okay. Okay, this one, only a summary report was provided to me after my latest DEXA. Her PCP suggested that she contact the imaging center to request because she doesn't have the detailed report. I haven't received a response yet from the imaging center and we'll call again, but is there any reason that they can't provide this info directly to the patient?
No, they should be able to provide it to the patient. Sometimes you have to go physically to where you had it done and sign a release, in order to get that. And then they can provide it on a disc or print it out. I don't know how they would do that. I've seen some places send a link where you have like a timed entry as a physician to get that result. So it just depends, but I would physically go to the facility and not rely on a phone call and somebody calling you back.
Yeah. There's a question about an experienced REMS operator. Would an ultrasound radiologist who normally does breast scans be able to do, okay, wait, I'll just read it. Would an ultrasound radiologist who usually does breast scans and did the echo light training be experienced enough to get a good scan when they start with REMS, or do they need to gain experience?
So I will talk about my experience because I'm an orthopedic surgeon and I know bones, right? So I will tell you your first 25 scans, it's a lot of it is about eye-hand coordination, right? This is a new skill that you're learning. I've used ultrasound and for other things for surgeries, but this is something different. So like I mentioned previously, you have to gain that eye-hand coordination. And your first 25 scans, I felt like that was all it was about for me. So I just had volunteers when I first started scanning. And then after about 50 scans, I felt like very comfortable with it. But then what happens as a clinician, you start to look at this and you look at DEXA and you're like, what am I seeing? And then you start to understand the interpretation of it. So as with any new technology or new skill, it takes a little bit of time. But I would say I think a radiologist who does ultrasound should be able to do this without any problem.
Okay. Sorry again. Regarding the slide Dr. Z showed about TBS, I understand it reflects bone quality. Can you review how the pixels capture it? The slide went by really fast.
No, I can't describe that because I don't really use that technology. I don't own a DXA machine, so I didn't look into that. But what it does is it captures your image, just like on your DXA, it captures that DXA image, right? And then it looks at, there's a computer software behind it that looks at the pixels. So the little squares that make up the image, and then it processes like, I'm going to use the word grayscale, processes the grayscale and makes an interpretation in terms of the where the grayscale is, and then it gets processed. So I think that's probably at how to describe it at the most basic level. But as far as the technology, I didn't read up on how that technology was fully developed, just like I did read on how REMS developed over time because I was curious about the basic science. I just didn't do that for TBS.
Okay, this is the last question. Ways to increase bone fragility.
So I think you want to decrease bone fragility, right? You don't want to be fragile. Right?
Good catch.
So you don't want to be fragile. You want to have good quality or non-fragile bone. So when we look at the fragility score, that means you want a lower fragility score, not a higher fragility score. The challenge that's happening right now is with this newer technology, we need the research to see what increases our fragility. I mean, decrease. See, now I'm sucked into that. What changes our fragility, changes the quality of our bone, and we just don't have that research. So when people ask me about how do I change my bone quality, my short answer is I don't have an answer for you, right? And so I think, again, look at the whole person. We are trying to prevent fractures, right? You can have, I've seen people who, by diagnosis on the REMS, have osteoporosis, who their fragility score is in the red, meaning they compare to people who have had fractures, and they have fallen and have not fractured, right? I don't want to encourage everybody to go out and fall as a stress test to your bones. But that right there is the best stress test. And again, these devices are screening devices. They're very powerful medical screening devices. And you have to look at the entire person. So if you're somebody who has normal bone density, your fragility score is in yellow, but you have a balance problem, nothing that if we worked on increasing your bone density and your fragility score, but we didn't work on your balance, you're at a loss. So you have to look at the entire person and stop. I mean, I'm doing REM scans. Come see me for REM scans, but I really want you to be empowered with knowledge. And I want you to focus on the right thing. And the right thing is to prevent the fracture. And look at yourself as an entire person, not just a bone mineral density T-score and not just a fragility score.
I think that
Sorry.
great. Oh, go ahead, Jana.
No, I just wanted to mention, I talked in the context of bone health, the discussion on how to increase digestion and absorption of nutrients, but that's for just overall well-being for anybody. So I never want somebody to look at, I have to do all these things to improve my bones. Like Dr. Zambito mentioned, like having a positive attitude, always thinking, I am healthy and I am strong and I'm doing all these things just because I want to have that much more energy and feel great. Because it's going to impact every cell in your body, not just your bones.
Yes, full body.
Yes.
Look at the full picture. I think that's a great place to end. Thank you all so much for coming. We really appreciate it. We hope that you took away some valuable information, some valuable bullet points today. And we are each here for you if you need us.
Thank you for joining.
Thank you for joining. Yes.
Thank you. Bye-bye.
Bye.